up and going. Wait, can you record? And then I'm like, oh, I can't remember how to do that now.
Yeah, and then what I'll do is I'm going to send a little link into the chat that would allow people just to join our mailing list. And if you do sign up to the mailing list, I can easily forward you the link to this session. You can unsubscribe at any time as well. And there'll be no hard selling of custom-made foot orthotics to those who do sign up. We might give you a little bit of educational content. So join on the call. I have my colleague James Ryan with me here, and James is a podiatrist, and he'll be speaking to you shortly. And also on the call is my colleague Sorcha Henegan. Hi Sorcha, can you hear us?
Hi Conor, I can, but your video is actually off. I don't know if you're aware.
Oh, I know that. James is putting his name on here.
Oh, James. Okay, that's fine. Hi everyone, how are you? Hi Jill.
Sorcha, hiya.
So what we'll cover today is we'll have a little introduction, which we're doing now at the moment. And a little change from what we've done in previous years. Previously, our colleague Sarah O'Connell, who was a podiatrist in Firefly Foot and Ankle Clinic, she's now branched out and she has her own clinic, and she would have presented to students across the universities last year. And she's moved on. James, who's here beside me, look, I'll turn my camera on, so you can see James. I can figure this out. Come on, camera. There we go. Morning, everybody. So myself and James are going to start things off in a minute or two, and we are going to have a conversation around James's journey to becoming a podiatrist. Oh, somebody else is coming along. What was a few of them? So we've got we've got like 50. I think we've got everybody on board now.
Lovely.
So James has started working with Firefly Foot and Ankle Clinic in the last number of months. So we're going to have a conversation about how he got into podiatry. He went back and studied podiatry as a mature student, and the journey that he took from being a student to becoming a professional who works in an MSK practice. And after that, so we'll have a conversation with James. Then James will deliver like a short presentation on your day-to-day working in the clinic, the considerations, his workflows and things like that. And then Sorcha will present prescribing custom-made foot orthotics. She'll talk about her order form, the types of products that we as an orthotic manufacturer supply to our customers. She'll talk to you about the materials that are involved and some of the considerations around that. And then at the end there, if we have time, I will demonstrate some of our 3D scanning technology. So commonly our customers will submit orders to Firefly using plaster of Paris to capture patient anatomy, to capture the foot. There might be foam box impressions, as I'm sure many of you are aware of. But more frequently, and what's becoming more common, is the use of 3D scanning. And a lot of our customers use iPads with scanners that attach. So if we have time at the end, if we have 10 minutes at the end, I'll just demonstrate that just so you have an idea of some of the technologies that are available in the industry at the moment, or in the profession at the moment. And that should bring us up to around up to around 11 o'clock. Now, I've got distracted. I'm looking to just grab a little link here. Just bear with me for 30 seconds. So the other thing to say is we are open to questions throughout the session. So if you're unsure about anything or you want to ask a question, just let us know.
You want us to ask out loud or in the chat? What do you prefer?
I think that is okay. I guess if you're going to ask a question, just unmute yourself, ask your question, and once the kind of conversation, the question is answered, just mute yourself again. And and that'll probably do it. Okay, here we go. So I've got my little okay, here's the little link. So if you follow the link, enter in your just make sure it's the correct one. Yeah, you just put in your name, email address, the university, so University of East London, and your graduation year. I'll also be sending out after this just a little follow-up survey to get your opinion on how you performed today and whether you thought the content was relevant, etc. So continue to improve. My God, there's loads of them coming in. So we've got the 20 people on board now. So there's a little link, so you can just click on it and fill it in. Okay, I'm going to close this down. So that's the agenda. I'll run through it very quickly again for those who just arrived. So my name is Conor Lynch. My name is Conor Lynch. I'm the sales and marketing lead at Firefly, and this is my colleague James Ryan. James is a podiatrist with Firefly Foot and Ankle Clinics, our clinical division. And later on, our client support lead, Sorcha Henegan, will talk to you, and Sorcha is on the call as well. Good morning, Sorcha. Say hello to those people who've joined.
Hi all, hi everyone.
So myself and James are going to kick things off with a little conversation, a Q&A, as I said, about his journey from a previous career to becoming an MSK podiatrist here at Firefly Foot and Ankle Clinics. Then James is going to present on his day-to-day kind of considerations and what he deals with as he works or when he works in Firefly Foot and Ankle Clinics. Then we'll hear from Sorcha, who'll talk to you about the prescription process, the types of devices that we have, materials that we use, the order form that our customers use. And finally, as I said, we'll wrap things up just before 11 o'clock, and I'll talk to you about our 3D scanning technologies and our Fusion app. So, any questions? Just unmute yourself, ask a question, and we'll take it from there. So we'll get things going. And so I thought it'd be interesting for you as a student cohort to just going to let some more people in here. I thought it'd be interesting for you as a student cohort to hear from somebody who has graduated relatively recently, had to find their way from being a graduate into the professional world, and yeah, I just thought that it would be beneficial for you to hear a story like James's. So James wasn't always a podiatrist. So what did you do before you got into podiatry?
Before you jumped into podiatry, I was working in the Irish Army for 5 years.
Okay.
So it was a bit of a mixed bag, I suppose, between here and podiatry. It was definitely a bit of trade tools. Yeah, and you were you were all over the world, I suppose, or all over Europe, I suppose. Yeah. Worked with the Irish Army originally for the first 3.5 years on my work experience. Then I joined up with the United Nations, and after that as well, kind of general logistics roles between Ireland and abroad. So yeah. And what did you, while you were working with the Irish Army, were you interested in or is that when you were interested in the kind of medical world came around? Did you start thinking that way at that stage? Yeah, it all cropped up. My interest kind of came up through my own experience. You know, I had an experience when I was working, and I had good exposure to some people part of the medical multidisciplinary team model. Right. Okay. Decided that maybe I should try and explore a little bit more. So came back and I started searching for what I want to do in the field of healthcare. So was podiatry at the top of your list at that stage? It wasn't even on my list at the time. Okay. But I was aware of it. I was definitely aware of it. I had my own issues when I was growing up and grown tall now. I suppose I just branched out when I came back, went back into an area of education to basically figure out, I suppose, what I wanted to study. So were you still in the army at this stage? I was, yeah. So I was doing a part-time course. I ended up doing an access course back into education. And through that access course, I had exposure to general healthcare
healthcare career paths. So the likes of physiotherapy, occupational therapy, podiatry.
Okay.
That's where I came across podiatry and Firefly as well for the first time.
Okay, so this back to education program that you're on, would you say that that was similar to A levels in the UK or the leading cert in the Republic of Ireland?
Very similar, yeah. So I had three choices. I could have gone down the road of applying through CAO or UCAS for college courses, but I also wanted to kind of freshen myself up and just take a stab at all general aspects of education that be related to my degree.
Okay.
So practice course is the way to do that.
And what degree do you have?
What degree do I have?
You didn't have a degree.
No, I never had a degree, no, just leaving like grade levels.
Yeah, okay. So, were you taking part in the access course while you were in the army? Did you complete that while you were in the army?
Yeah, I did.
And how long did that take you?
It was a year of Mondays and Tuesdays, so part time.
And when you completed the course, you did an application through UCAS or the CAO in Ireland.
Yeah.
At that stage, was podiatry at the top of your college course selection list?
It was, yeah. No, so I through my time in the short in the access course, I exposed myself to different professions, like physiotherapy, occupational therapy, podiatry, and I had some really good experience with a group of podiatrists, and I decided that I'd put that on the top of the list.
And where did you get that exposure? So I suppose this is kind of important because was it the start of your kind of networking in the world of podiatry and maybe the MSK world?
Yeah, definitely.
So who are these type of people that you're talking
to? For the most part, it was Firefly. So I was actually Mark McGill, the medical director of Firefly here, and he kindly gave me a week to just sit in and practice with himself in break.
Yeah.
And there's a few other people as well that I had conversations with, sat down and figured out what the day-to-day life of podiatry or podiatrist was like.
Okay. What universities did you have on your college application?
For the most part, it was Republic of Ireland, Northern Ireland, but it was really kind of going for Galway.
Okay. And you got accepted in Galway?
Accepted in Galway.
And I wonder, so I think like we have an understanding, or at least I have an understanding, that a lot of undergraduate podiatry students in the UK their courses are geared towards NHS and maybe the at-risk foot. Is that fair to say?
Yeah.
Is that similar to what you experienced when you were in college?
Yeah, it'd be very similar. I suppose when I look at the HSE and I look at the Irish education system, we were very much geared towards HSE work and again care of the at-risk then.
Okay.
JQ diabetes.
And so were you gaining, I presume you did placement when you were in university?
Yeah. From second semester first year, I was in some sort of placement on a weekly basis, and then towards the end of my college career, I was off on placements as well, block placements that likes of St. James's Hospital in Dublin.
Okay. And were you working in multidisciplinary teams there?
Yeah, there was a full exposure to MDTs. I was working with physiotherapists, tissue viability nurses, doctors, surgeons. So it was pretty nice.
But again, a lot of this is the diabetic and the at-risk foot. Yeah. And so I guess you made a bit of a jump from, without getting ahead of ourselves, but you made a bit of a jump from what you were looking at primarily in university to where you're working today in regards to the different types of podiatry, different types of podiatry practice. So while you were in university, and that's to say that you were working as primarily an MSK podiatrist at the moment.
Yeah.
Is that how you describe yourself?
I suppose it would be.
Yeah. So while you were in college, did you get any exposure to the type of podiatric practice that you're taking part in today?
Not a massive amount of practice, I suppose, regarding MSK podiatry. The first time that we had full exposure to MSK was the second part of my third year in college.
Yeah.
And it was just the way that I met. Now the course has changed since then. But yeah, we had first exposure second semester in year 3.
And what were you looking at, or what sort of what does that look like, that kind of experience?
Always different planet, I suppose. When we're primarily geared towards the likes of wound care, athletes, and then we're jumping into MSK paradigms, and we're looking at athletes who are injured for one reason or another, and coming to podiatrists, physiotherapists to find a solution to their problems.
Okay. So you're looking more at athletes and things like that, and
Yeah, that and the everyday person is a good blend, I suppose.
okay. So did you, while you were in college, did you have any practical experience of MSK? Did you get any kind of work placement in that area?
Not necessarily. I had exposure through college, so when we have a good blend between the HSE and our university, as it's a joint course sponsored by the HSE. We managed to get a branch into the MSK world in our regular clinics. So every 4th week we have exposure to MSK patients, and you'd be there with MSK specialist podiatrists.
Okay.
And you'd be taking a consultation with them, watching how they work, and learning how to run a few different clinical assessments yourself.
So how did the introduction of MSK podiatry kind of change your mindset? Was it like opening a new world of MSK, or how did it strike you when you got introduced to it?
It was just great to see the scope. I think we were all aware of the scope that we have in podiatry and the different places that you can go, different fields you can work in, specialize in. And we hadn't really had that exposure up until that point. So it just gave us, I suppose, view through the looking glass and a different career path that you take after you qualify.
Is there a similar learning curve if you were to push, the MSK podiatry besides wound care or the diabetic foot?
It's, I suppose, all roads should lead from A to B. All roads lead to Rome. It's hard to say that they're both similar to each other. With the likes of wound care, it's very straightforward. You have to achieve a state of wound healing. When it comes to MSK, there's a number of different factors that I suppose you have to take into consideration. So there's a lot of kind of subtle nuances that you can kind of pick up along the way with MSK.
Okay. And when you were in college, did you get an introduction to orthotic therapy?
Briefly, yeah.
And what does that look like? This is an orthotic.
This is orthotic, yeah. Also, it was, I suppose, varus wedging. So
Okay.
it was, I suppose, what we again briefly touched on paradigms, the likes of sagittal neck facilitation model, Kirby's model,
Root.
root as well, which is kind of, I suppose, historical at this stage.
Yeah.
It's important to remember where we've come from. So it was more so kind of a broad brush stroke on theories. This is an orthotic.
Yes.
This is a varus tilt or knee wedge.
What about the practical aspects of anatomy capture? Did you do anything like that?
We learned how to foam box and cast, but say a little bit, we didn't really use it in practice. So there was never a patient that was in front of us that we casted and sent off and saw the finished product.
Right. Okay. With your experience that you have now, so how long have you been working in as an MSK podiatrist in Firefly Orthoses clinics?
Since September 2021.
Okay. And obviously, is there a massive difference in your day as an MSK podiatrist in comparison to when you were getting experience in St. James's Hospital or a field like that?
I think the variety of patients is definitely something that I kind of noted. There's a bit of a broader scope. Primarily MSK podiatry. I do an awful lot of MSK. I have an awful lot of MSK-based patients, but I also do routine care. I do the likes of shockwave therapy as well for any kind of chronic conditions people might be having.
Okay. What is shockwave therapy?
Shockwave therapy, it's we use basically for the likes of, if I was to use an example, the likes of chronic plantar fasciitis, or Achilles, issues of Achilles tendinopathy, tendinosis. and you'd be using shockwave to help start a period of healing in the body. So what it does, it sends low frequency sound waves into dysfunctional tissue, and it helps break it down and helps bring inflammatory mediators down into the area to promote healing.
Yeah, okay. Just going back to college a little bit, and actually I must remember to ask you about the other kind of technologies that you use.
Yeah.
But going back to college, before you graduated, did you have a job lined up? Did you know where you were going to go?
No, I was definitely keeping my finger on the pulse. I was asking around. I kind of developed a few relationships with people that are already in the field when I was an undergrad. So I was keeping an eye on it. I had few interviews as well. So.
Okay, so you had, so you did have, so I suppose what you're saying is you didn't know exactly where you were going to end up, but you had a couple of options.
A couple of options, yeah, or an idea.
An idea, yeah. And that was through creating a network or connecting with the network of podiatrists that are out there.
Mm.
So that's something that you would say, I presume you'd say that's an important aspect of, like, it's kind of learning outside of your.
Just kind of jumping outside the box,
Yeah.
Thinking outside of it.
So while you're in university, you've obviously got your coursework, but at the same time, you were thinking about, well, I'm going to finish this course in 2 or 1 year.
Yeah.
And I need to be able to go somewhere afterwards.
Mm.
So you were. How did you create that network of contacts in the podiatry field?
Well, I suppose I knew a few people in the industry originally that I kind of, I suppose, kept an eye on, that I was in semi-regular touch with, other things that I used to keep in touch. I suppose joining the likes of Facebook pages are quite good. Social media has really kind of exploded the, I suppose, realm of intercommunication, like the likes of LinkedIn.
Yeah.
LinkedIn account as well, that I don't use all too often anymore. But that was always good for kind of touching base with people. You know, it's like, yes, I'm training to be a podiatrist and I'll be graduating such a date. And even if curiosity gets the better of you, going and asking questions to people, you know, most people are pretty happy to answer.
So would you say to people on LinkedIn, hi, my name is James Ryan, I'm due to qualify very soon. I love your work.
No, I don't really fan well, but no, I'd say more so if I'm looking at the way that I approached it. I was touching base with the likes of Firefly and a few other companies around Ireland that I was in touch with, people that I connected with through placement. So
yeah,
the likes of my final year placement in St. James Hospital in Dublin, Christmas card list with my head lead podiatrist there. So
okay,
that kind of stuff. CPD sessions, so continuous professional development. You can do those before you graduate if you have the time to do it.
Yeah.
You can do them afterwards as well. They're absolutely fantastic. I was only at one a few months ago down at work.
There is just a few more people I need to add here, I think. The other question that I was going to ask you is, I guess it's good to ask people for kind of come in and do a couple of days with you, just shadowing, or is there some way that I can get kind of experience? I think people are open to people. I would guess it shows that this particular person who's asking is interested in what we do, and that's probably a good thing, a good starting point for anybody who's looking to get on board.
Absolutely, yeah. No, I think it's important. I think a lot of people are pretty willing to help nurture the young professional as well, you know, and I suppose help them grow their skill set, or at least expand their scope and what's available to them as a clinician when they qualify.
So you would build a relationship up with Martin, who's the medical director and founder of Firefly, and so you started working with Firefly. So what did that look like? What were your initial weeks? When you came in the door, were you just given a patient list and said, "Don't get stuck into it"?
Yeah, no, it wasn't like that. No, so it was actually really structured. I still do a monthly clinic with Martin.
So how long are you working with Firefly?
Firefly since September of 2021. So that would be
yeah. So
originally I was shadowing another podiatrist that was working in the clinic, so I was sitting down with a young podiatrist that was working here on a weekly basis. And they started to slowly expose me to, well, first of all, general everyday routine cares, which was absolutely fine with me. And then as time went on, I started to get a bit of a slice where it was a joint consultation. I was sitting in with the podiatrist. We were both talking to each other through the clinic.
Yeah.
And then after about, let's say probably the 8-week mark, I was just had my colleague sitting in the corner watching me work and kind of troubleshooting anything that I might be missing out on.
Okay.
As part of the consultation.
And how did you graduate then towards running your role and being solo in clinic with the patient?
I suppose there's a gentle progression then into that case where it's okay, everything seems to be good. You have a list of supports beside you, so I have the likes of Martin's mobile number. I can send him a text message if there's anything that I'm querying.
Okay.
So now at this stage, I do run my own clinics. I run a clinic with Martin once a month. For any kind of specialist cases or anything, any points of interest, any old patients that Martin has had that he wants me to experience with them.
Okay.
And his clinical practice and the way that he flows through the consultation.
Is it the case that you might see a patient on a particular day in clinic and you assess them and you'd be working towards identifying pathology, but you mightn't be just 100% sure? Is it the case that you don't have to solve that problem there and then on the date that you've got, as you said, you can touch base with Martin and other podiatrists that are working within Firefly to get their opinion and then get the patient back in and kind of work them through a journey? Is that something that happens?
That's something that absolutely happens.
Yeah, okay. So your kind of structured learning is still taking place to some degree in Firefly.
Every day,
Yeah.
definitely.
So now that you do see patients solo and such, do you have like an approach? How do you, when the patient walks through the door, how do you approach that kind of process of?
Every kind of, I think there's always a blueprint. There's always a blueprint to your clinical practice and the way that you approach each consultation. But I think it's important that you kind of keep it in mind that every patient is different.
Yeah.
So like there's different goals, different age groups, fitness levels, everything that's kind of intrinsic and extrinsic to that patient has play in how you guide yourself through that particular consultation.
Okay. One of the last things I wanted to ask you about, and we spoke about it a bit earlier on, is the type of technology that you use. So you spoke about shockwave therapy for tissue treatment, I guess.
Yeah, so soft tissue primarily is what we use it for.
And what else do you have? Do you have something for the treatment of verrucas and warts?
Yeah.
Swift?
Yeah, we use Swift. We use other. We've plenty of I suppose toys that we use for treating the likes of verruca, because it's one of those ones. It's very hard to treat each verruca in the same way and expect the same clinical outcome.
Yeah.
But Swift is something we brought in the last 5 months that we got.
Okay.
There's a lot of success with it as well.
Yeah. And when you started working in Firefly, did you find the area of orthotic therapy, prescription of orthotics, a bit of a leap from what you had trained in?
Absolutely, yeah.
Was it like you had to kind of start again to some degree?
To some degree, absolutely. That was great though, there's, again, when I look at the clinic exposure I had with other podiatrists in Firefly, and then the team that we have as well in the background, just kind of cleaning up after us and making sure that everything's working the way that it should.
Yeah.
So our tech support in Firefly was absolutely fantastic. If I had any question under the sun, I had the luxury of walking out the door, up the stairs, and just having a chat with the clinical ops team there.
Yeah, so I suppose James is in the privileged position to. So we're in one of the clinics at the moment, and through the wall is the Firefly Orthoses lab. So any device that you prescribe and that you're fitting to a patient, if there's any tweaks that are required for fit and comfort, you just run into the lab and have those tiny little adjustments made to ensure that the product fits exactly as the patient requires.
Absolutely, yeah.
So we're going to finish up our little Q&A with James in a minute now. And if you have any questions that you might want to ask James about, put him on the spot now, about his career or how he progressed from university to becoming a landscape podiatrist, just ask and I will answer. But before we finish up, what do you think? Do you think that there are, what sort of opportunities are out there for a qualified podiatrist? And I suppose I asked that question in the context of, we go to conferences, shows, and we meet students. Sometimes they feel that it's very, they're very much, the training very much focused on diabetics and at-risk push. But is it fair to say that you believe that the opportunities out there are, for those that are interested, that's great. The diabetic world is there for you. But outside of that, is there a broader range of opportunities for the podiatrists?
I think so, yeah. Well, again, if you look at different fields, the likes of, you can look at cardiac at-risk limb, you can look at routines, MSK as well. There's a lot of different rabbit holes you can go down in your career path.
Yes.
But generally, I think there's great exposure in Ireland and the UK. Plenty of job opportunities. Every other day, in LinkedIn, I'm getting a notification of somebody who's looking for a podiatrist in some part of the country.
Okay.
Opportunity to travel as well is massive. There's the likes of Canadian system, the Australian system, New Zealand. There's a lot of scope there, I suppose, for anyone who wants to practice in different parts of the world and pick up in different practices.
Yeah. Okay. So we've got some questions here. So Grace asks, what prompted James to get into podiatry in the first place?
Well, I suppose kind of exposure to Firefly here was a big factor. But initially, the first time that I was aware of podiatry was when I was about 12 or 13. Horrific ingrown and it's fantastic.
Okay, so you knew what a podiatrist was from an early age.
Yeah.
Okay, and you knew how effective they could be.
Absolutely, yeah.
Jim asks, what have you learned in Firefly that you wished you had been taught at university?
That's a very good question.
I think one of the, from what I know about your experience at university, one of the interesting aspects of your university journey was that the introduction of MSK. So Adam McIlwain is a lecturer. We've had two members of staff who have moved from Firefly to lecturing in the National University of Ireland in Galway. And one of them was Adam McIlwain, and he would have delivered a lot of educational content for Firefly when he was here. And was he one of the driving forces to introduce the MSK side of things into the program in Galway?
Yeah, he's definitely one of the kind of, I suppose, the newest additions to the MSK world in NUI Galway. So he was, I suppose, one of the leading factors that kind of got me into the world of MSK podiatry. It's the reason that I wrote a dissertation on planning issues when I was coming into my final year of college. So yeah.
Okay. Okay. Well, if nobody else has any questions for James at the moment, we will take a 2-minute break, and then we'll come back to you, and James will present on his daily experiences in Firefly and some of his considerations there. So if it's okay with everybody, we'll take a 2-minute break. We just shuffle the slides around here a bit, and we will be back to you very shortly.
Hey guys, how are you doing? So I'm just gonna pop this up on the screen. Perfect. Hope everyone can see me okay there. See the slides. So I'm just gonna have a wee chat to you guys about what my clinical practice looks like on a daily basis. So it's just a couple of short slides to talk to you about how I approach each patient, what kind of paradigms I'm looking at on a regular basis, and then as well on top of that, clinical tests and common pathologies that I come across in clinic.
Sorry,
So,
James. Sorry.
yeah.
Just a quick one. The screen isn't sharing,
The screen isn't sharing.
so we can just see you in clinic.
That's unfortunate. 1 second. To call in tech support. That's not sharing at all, is it?
No, we could just see you, not the slides.
Tech support. I wasn't sharing.
Oh, okay. Oh, sorry. I know what to do. Yeah. This is not straightforward.
Yeah, perfect.
Excellent. Okay.
And then we're going to go. All right.
Same. Thank you. Very good. Okay. Sorry about that. Okay. So, I suppose again, we're going to be talking through my clinical practice on a daily basis. So, first thing I suppose to note is patient history. So, when we're looking at patient history in Firefly, we do 2 different ways. Before a patient even walks in the door, we send them out a questionnaire which is filled out. Hopefully, for the most part, they're all emailed back in. We print them out so we have an idea of the patient that's coming into us before they even step through the door. So that kind of closes off the majority of closed questions that you'll be looking for a patient on a consultation visit is kind of covered in that setting. Now, when the patient does come in the door, the other aspect of patient history is have a little bit of an open question session with them at the start. So when you're looking at that, I suppose it's important to have a bit of a clinical blueprint and what your consultation looks like. I generally leave about 5 or 10 minutes, depending on the amount of history that I need to take from the patient. So that kind of takes care of most open-ended questions. So after we've taken a good history of the patient, the second most important thing on clinic is anatomy. So anatomy is probably drilled into you from day one, but I guarantee you that even when you do qualify, it'll be something that'll be very relevant. It's something that I occasionally dip into. So if I get an extra 10 or 15 minutes during the day, I'm looking at something, I'm opening up Grey's Anatomy textbook, or I'm having a look at the likes of teachmeanatomy.com to do a quick refresher on something that I haven't gone over in a little while, just to keep everything turning over. And the next thing I suppose that's important in clinic is to have your patient's goals in mind. So when I have patients in, I have a wide range of individuals that come in through the doors. Only in the last few months, I've had one gentleman who came in and he was looking to best his marathon time. And I had another lady as well who wanted to walk her daughter down the aisle in 12 months' time. So with patients' goals in mind, you can't really go too far wrong, and you can try and facilitate some sort of care for them through your own clinical practice, or again, refer along to other professionals in the field who can help. And time management as well, that's something that does come with time. So like some time management and things that you can do to, I suppose, help yourself along the way, have a good clinical blueprint. So just, again, as I was saying at the start, 5 or 10 minutes for a patient history, then you go into your standard assessments, the likes of your weight bearing, non-weight bearing, dynamic movements, depending on what you want to do. Having a watch, so the likes of watching your wrist, or a clock on the wall, just to keep you in the know of how much time you have left in your consultation, when's the next patient coming to the door. All really important things to kind of take in mind. And then note taking as well. So note taking as well is something that it's always going to be important for you. It protects you, it protects the patient, and it also helps you come up with the best or the optimum treatment plan for that individual that's walking the door to you. So MSK paradigms. So there's a lot of paradigms out there when it comes to MSK therapy. So it's not quite the theory of everything just yet. The goal would be, overriding goal, to have no paradigm shift in the world of MSK, but that hasn't happened, and I can't see it happening anytime soon. That in mind, some of the paradigms that are out there, traditionally what we have is root theory, which I'm sure you're probably all aware of at this stage. You know, it's definitely something for the history books. It's important to see where we've come from as a profession and what we've developed to up to this point, and to see where it goes from here. And then we have the sagittal plane facilitation theory, which is one that we use regularly here in our clinic. We have the Kirby model, again, it's another important one to keep in mind. We have the Fuller model, we have the tissue stress model, developed by two physiotherapists initially, and we have the Dempf model, which is a mathematical based mix between podiatry and maths. Dr. Philip Dempf, who was both mathematician and podiatrist. The list goes on, but I suppose what I use regularly on a regular basis would be the likes of the tissue stress model and the sagittal plane facilitation model. And what we're looking at there is the sagittal plane facilitation model is the rocker bottom aspect of the calcaneus, the rocker bottom aspect of the metatarsal phalangeal joints, and to ensure that there is a minimum of 10 degrees worth of dorsiflexion before heat off in the foot as it moves dynamically. And then the tissue stress model, which is all down to the loads and the zone of optimal stress of the tissue and what it can take before it starts to become dysfunctional. And that's what I try to use on a daily basis whenever I have an MSK patient in front of me. If I'm using the likes of orthotic therapy, or if I'm prescribing any sort of exercises to the patient, generally these two do lead me in the right direction. So again, all roads should lead to Rome. Now I have clinical tests for you. So the likes of clinical tests that we use on a regular basis in Firefly. Now, again, it's much like a recipe, and no two patients should be the same. But just a few different clinical tests that I use on a regular basis that kind of help me out with them. They go into subcategories of non-weight bearing, weight bearing, and dynamic movements. So the likes of non-weight bearing, I'm sure you're aware of the likes of range of motion tests, small joints assessments, muscle power. Then other ones, I suppose, if we're looking a little bit further up the line, the Faber test, we're looking at the hip and hip range of motion and mobility, leg length discrepancy to see if there's a difference between right and left. Always important as well to keep a note of. The likes of weight bearing tests. We have the JAX test, supination resistance, foot posture index, and single limb balance. Now, again, this is a list that, you know, it's inexhaustible really. But again, it just really depends on the patient that you have standing in front of you. But these kind of clinical indicators can give you a good idea when you're looking towards the likes of diagnosing a patient with a particular condition. And then we have dynamic movements, dynamic assessments, the likes of the gait assessment. The gait assessment can be run as simple as having a patient walking up and down a hall or through your clinic. You can have them up on a treadmill, or you can have them walking across a pressure plate. The likes of the knee to wall test as well, to test for ankle dorsiflexion, just to see where your range of motions lie on a dynamics scale. A squat test and a single leg calf raise, again, two good clinical indicators when we're looking at how the feet and the legs track as they move. And the likes of a single leg calf raise to identify any tissue dysfunction between right and left. So again, as I said, it's a tailor-made experience. So each patient that comes in the door, I don't necessarily look and have a checklist and ABC to see if they're done. It really does depend on that patient. So common pathologies that I come across in clinic on a regular basis. So these are all pathologies I've come across in the last few months. So severs, if we're going down the scale, we're looking at kids, pediatrics. Severs is a very common pathology that happens with a wide range of kids. Typically, you're looking at a physically active child. It's training multiple days a week. And then when we look as well at soft tissue of the posterior chain of the foot and ankle, and leading up the chain up the leg. Traditionally, we'd see an awful lot of tightness in patients that come in through the doors to Firefly. Then I have the likes of Achilles tendinopathy, tendinitis. Again, there's a range of people that come in the doors when this particular pathology presents itself. I could have an athlete who's an avid runner, or I might have somebody who's a farmer in the west coast of Ireland, and it really just depends. I suppose relationships there with soft tissue tightness as well on the posterior chain have a heavy link to it. Now, again, that could be acute or chronic issues that are presenting themselves. It's important to be able to identify between the two of them. And plantar fasciitis. Plantar fasciitis is another one that comes up on a regular basis. It's also one that's often misdiagnosed, particularly by patients. And so Dr. Google does help, or point patients in the wrong direction sometimes. Plantar fasciitis is one that does pop up on a regular basis if you type in plantar foot pain into Google, and it's important to either be able to identify that or to identify something else that might be going on in the soft tissue bony structures in the foot. And the likes of Morton's neuroma as well, again, another very common one, and unfortunately more common in women than men. Again, Morton's neuroma pathology, you're talking between your second, your third, or your third and your fourth metatarsus. And generally what you're having there, you have an enlargement of the neurological structures in the foot, and that can cause a lot of discomfort for some patients. And then we have the likes of posterior tibial tendon dysfunction and adult-acquired flat foot, which posterior tibial tendon dysfunction can lead on to. And again, these are all pathologies, I suppose, that can be treated in multiple different ways. For the most part, we want to look at being as invasive as possible, so trying to reduce the amount of interaction that we have with the patient. So if we can be minimally invasive and get a patient from A to B through strengthening, exercising, and helping increase the person's range of motion, absolutely fantastic. If not, other things that we can look at be the likes of orthotic therapy. Now in Firefly, we do both types of orthotic therapies. We do an over-the-counter orthotic. We also have a sorry, there's a lovely problem on the screen. So we have over-the-counter orthotics, and we have custom-made foot orthotics. Custom-made foot orthotics is something that we specialize in. And so it really just depends on that patient presentation and what we think will help the patient, or what the patient will benefit from the most. And I'm going to pass on now to casting and scanning. So casting and scanning, this is my last slide. And so again, when I'm just briefly glossed over over-the-counter and custom-made orthotics, we look at casting and scanning for the when and how. So again, as I said, graduate and conservative treatment plans are kind of the number one in Firefly. So when footwear activity modification and strengthening exercises do fail, the likes of over-the-counter therapy, custom-made foot orthotics, and as well ankle foot orthotics, which is something that I hadn't mentioned before, the likes of bracing therapy that we use for above the foot. So the likes of Ritchie brace for ankle therapy, if we have a patient that comes in the door with adult-acquired flat foot. So again, we want to look at benefits of intervention. I mentioned it before as well, the zone of optimal stress. So what we want to do is, when I'm taking the tissue stress model into account, is bring that patient into an area where we can facilitate healing. And the likes of foot orthotics and ankle foot orthotics can be a solution to that on an occasion. And then I have casting, scanning, foam boxes. So it really depends on what you're exposed to. The guys are going to go into the types of scanning that we use in Firefly here on a regular basis, which would be primarily infrared cameras that we use on the likes of a little device like this. And then we have casting as well, and foam boxing as well when scanning goes out the door. Casting as well is something that we use here in Firefly on a regular basis. And with that, I'm going to pass you on. I think Conor's going to pop back in a few minutes. Does anyone have any questions for me? Perfect. I think that's okay. And he comes in a second. Okay, guys, thank you very much. Yeah. Pass you on.
Well done.
Well done.
Good stuff. Any questions for James before we progress on to sorry, we might take another 2-minute break just to get our slides in order. Actually, I'll hand over hosting to Sarah. Let's make sure there's no. Okay, Sarah, I'm going to give you hosting.
Okay, great, thank you.
There it goes.
Okay. I will just.
Sarah is our client development lead, and she works with a lot of our new customers, getting them onboarding them with Firefly. So we would have I suppose each orthotic lab has their own kind of unique ways of, they'll have obviously unique prescription forms to prescribe devices, and they'll have their own terminologies maybe, and idiosyncrasies around device types and things like that. So even though podiatrists might be experienced in the prescription of custom-made foot orthotics, they still will need kind of an onboarding process to make sure that they understand the particular orthotic lab's offering. So Sarah will work closely with customers, new customers mainly, and she would then kind of interface between our operations and our technical support team. And one of the unique aspects of Firefly Orthoses is the technical support that we offer to our customers. So, the technical support is relied upon by customers who are not just inexperienced, but it can be fair to say that some of our customers who are most experienced and who prescribe most amount of devices per month and per week and per month would use this more often than not, because they know that they might not have all the answers in relation to the technicalities of the prescription process, and that's what our customer support and operations team are there for, to offer that information. So we know it, so you don't have to know it in some ways. All right, maybe that's not the best way to explain it. You should know it as well, but we're there to be relied upon. So do you want to take it away, Sarah?
Yeah, I will. Thanks for that, Conor. Hi everyone. So like Conor said there, I am the Firefly client development lead. So I help people with onboarding new customers. Also, if you have a new podiatrist in your clinic, I go through our prescription forms, our device types. The idea would be to make you as comfortable as possible when prescribing. So I would kind of hold your hand throughout that process. Your first couple of orders, I'd always contact you to discuss them, make sure that you're happy with them before we proceed in manufacturing, things like that. I was the operations and technical support lead for a number of years before I went into this role, so I have extensive experience in this area. And what we're going to talk today about is our prescription form. We're going to go down through the prescription form in a little bit of detail, and just, I suppose, to bridge the gap between you guys as students and then when you go out into the professional world, how you would complete prescriptions such as the Firefly standard device prescription form. So I suppose the first two considerations when you have decided that you're going to prescribe for a patient of yours would be, what are you trying to achieve, firstly? And secondly, what footwear type are we looking to fit these devices into? That's really, really important, because if you're adding additions, extensions, things like that, and they don't fit into the patient's shoe, then the patient won't wear them, or you'd have to send them back into us, and it's overall not the best experience. So the way I see it is to try and stop the train before it leaves the station by you guys giving us as much information as you can. Information such as patient name, date of birth, footwear type, weight, and shoe size. So all of those details are really imperative. Patient name, obviously, because we need to have a reference for the patient. Date of birth gives us a really good insight as to the person behind the prescription. Their age might tell us a lot. If the patient is under the age of 16, we automatically register them for our outgrowth program. If, for instance, we see that the date of birth a patient was born in 1939 or 1940, and we have a prescription in front of us with that date of birth and a polypropylene semi-rigid shell, we would then contact you and ask the question whether you think that that patient will be able to tolerate a semi-rigid polypropylene shell due to their age. Without the date of birth, we wouldn't know to ask that question. So I think that's where it's really important to have as much information as you possibly can. There's no such thing as having too much information. That's what I always say anyway. Footwear type then. So footwear type tells us what footwear you're trying to fit the devices into. We could be looking at heel cup depth, the grind of the device. Without the footwear type information, we can't ask the question. So by having that, some people would write in various. They want to fit the devices into a various range of footwear types. That's okay, that's no problem. But you might see trainers, you might see brogues, loafers, ankle boots, walking boots, regular echoes, things like that. So all of this information gives us an idea as to when we are manufacturing the device and manufacturing the prescription orthotic, that when you get them, that it's the best chance of them fitting into the patient's shoe. Weight is extremely important because weight plus the rigidity equals shell thickness. So we have a matrix in the background that we will determine shell thickness once we have the patient's weight and the weight and the rigidity. Shoe size then will determine the length of the top covers and the width of the top covers. So that's really important to have in there. Prescriber details then will be your details or your clinic details that you're working in. Then in column 3 there, order info, date, that's just the date that you've seen the patient. Rush then is if you want the device rushed for a patient. Post to patient is if you want the device posted directly to the patient, not to the clinic. And repeat order then is if this patient has had an order previously, that you want a repeat order of that number. Duplicate means an exact repeat, no changes. And then change then would be that you want to have a second set with the changes that you've marked below in the rest of the prescription form. So this is just the top of the form. This is the most basic details that you can put in. Next we have I suppose wondering what you're trying to build. Are we trying to build a functional device for this patient or a palliative accommodative device for this patient? So functional orthotic devices aim to change the load going through the foot. So for instance, if you had an elderly patient, you're most likely not going to prescribe a functional device. You're most likely going to prescribe a palliative or accommodative device for that patient, like that 1939-year-old patient that I mentioned earlier. There must be movement in the foot in order for a functional device to work. So there can't be a rigid kind of foot type really. The shell materials that would predominantly be used for functional devices would be polypropylene, carbon fiber, thermoplastic, and Delrin. A palliative device is to accommodate an arthritic, painful foot. It's for maybe someone with hypersensitivity, or like that, your elderly patients who you're trying to maybe offload the forefoot areas, or something like that you're trying to just have something comfortable for them. There's little or no movement in the foot, and we must accommodate the shape of the patient's foot. And the most common devices there or the most common shell materials would be EVA or cushion cork. So that would be your specialized devices like your diabetic, tri-density, or a soft mold and EVA devices, which we'll speak about later. So then we're on to column 4. So this is probably the most important column on our form, because this will determine what the device is going to look like. This will determine usually what shell material it's made of, what length it's made of, because all of these devices come with default specs. in our lab catalog that we would send out to every customer. So you'll see there are headings: functional, dress, sport, and mold. So functional, dress, and sport, they basically they would kind of determine the width and the grind of the actual product itself. So for instance, we might just go down to dress device. So if you think of a dress device, you think of a low heel cup, you think of slimline. If you think of a sports device, you think of a higher heel cup. So the higher the heel cup, the wider the device, the lower the heel cup, the narrower the device. And that's just something to kind of, as a rule of thumb, to keep in mind. So dress would be low and narrow, sport will be high and wide, and your functional then is your in between both of them. So standard functional or functional devices are, I suppose, your everyday type of footwear, or if you're trying to fit them into a variety of different shoes. So it has a functional grind, which means that it's nicely tapered in. The differences there between standard and direct milled would be the manufacturing process made or designed to make the devices. So standard functional devices would be made from polypropylene or carbon fibers, Performance RX. Direct mill then could be made from polypropylene or Delrin. We'll talk about them later. But I suppose the differences between them there is, for every vacuum form device that you would prescribe, for every left and right foot, for every left and right scan, we need a left and right MDF mold, positive, manufactured from that. And that would be for the shell material that you've chosen to be heated and vacuum pressed onto that positive. So as you can imagine with that, there's a lot of wastage, whereas with the direct milled manufacturing process, there's much less wastage because the actual shell itself will be milled from a polypropylene block, so there would be much less wastage and it's a more cost-effective option. Our dress devices then, you see, you have standard slimline, low heel cup slimline, flat heel cup, and Cobra. Standard slimline would be our gold standard for a lady's dress. If you were kind of worried about kind of the devices fitting into a patient's shoe, if they had really kind of a low pitch of an ankle boot, for instance, then you could bring down to low heel cup slimline. The only differences between the two will be the heel cup depth. So the heel cup depth for a low heel cup slimline will be 4 to 6 mil. The heel cup depth for a standard slimline will be 8 to 10 mil. So it really just needs to take into account what you're trying to achieve. If the patient needs that extra bit of heel cup, you might need to tell them that, okay, well, we need to prescribe these devices with this amount of heel cup. We're not 100% sure if they're going to fit into this footwear, but do you have any other footwear that you think that they might fit into? Any other boots similar to this with a bit more room in it, kind of things like that. So I think that communication with the patient in clinic is super important, and for them to understand as well when you're asking them maybe to change their footwear type or something like that, that they understand the reasons why. Okay, so then we have flat heel cup then. So flat heel cup is basically as it says in the tin. There's no heel cup at all. It's just a flat, it's right under the heel, will just be a flat piece of plastic. There's no roof upholstering allowed to be applied in it because there's no heel cup. I would usually suggest, if you're looking for a flat heel cup, to maybe go for a low heel cup slimline and maybe bring the heel cup height down maybe to 2 mil or keep it at 4 mil, because it's not going to do anything really for the patient. It's more so really for MLA control. That's all that would be for. Cobra devices then, they have no heel cup as well. We can't apply any roof postings to them. They're for high heels 3 centimeters and above. They have like a hanger type shape in the heel for fit. So that as well would kind of be more kind of MLA control but ever so slight, because we can't have any rear foot postings or anything. And then men's dress then just has a slightly wider grind, because usually your men's foot would be slightly wider than the lady's foot. So it just has a slightly wider grind than your women's standard slimline, but it's pretty much the same. Then we're on to our sports devices. So these would be for trainers. You see there, you have a low profile. That would be good for cycling shoes, golf shoes. You have soccer sport there. That's good for our football boots, rugby boots, soccer boots, things like that. So standard sport then has a 16mm heel cup. It's a full length neoprene top cover, so it's that wetsuit material, but it's really cushioning, really durable. So the difference then between standard sport and low profile sport would be the heel cup heights. So instead of 16, low profile has a 12mm heel cup, and it has thinner top covers with additional cushioning in the forefoot. Impact sports devices then, these will be designed as, I suppose, if your patient is a runner, to the really shock absorbing devices. So they'll be designed to kind of reduce the impact for the patient. You'll see there with rear foot post and with dual density rear foot post, that's where you're changing it from a more shock absorbing device into a more controlling device. One thing to note is that with an impact sport, you have an underfill of poron. So underneath the shell is filled up with poron, which increases the bulk of the device as well. So whenever you have an infill or a fill material, that means it's going to increase the bulk of the device. And then soccer sport then is our only device that comes with a carbon fiber shell as default. The rest of the devices, bar our diabetic tri-density or a soft mold and EVA device, all come with polypropylene shells. They also all of our products come with semi-rigid polypropylene shells, bar our mold devices, which I'm going to speak about next. So mold there, you'll see standard and you'll see low profile. I would usually describe your mold devices as your halfway between a functional and a palliative device. It has an infill for shock absorption, but it usually comes with a semi-flexible polypropylene shell. So why it would come with a semi-flexible polypropylene shell is because when you have a fill, it slightly increases the rigidity of the device, but when it's semi-flexible, it's still not going to be as rigid as if you had chosen semi-rigid. So it's kind of your midway house between a functional and a palliative. It could be where a patient is developing sensitivity or developing OA or RA, and you just need something a little bit controlling, something that's not completely soft like our RA soft mold, or something that's not functional like our standard functional. So it is your halfway house. So then our softest device then that we have is our RA soft mold, and you'll see there our diabetic and RA devices can now be ordered using the specialized device order form. So that's a different order form that we have, but it would be mainly designed for NHS trusts or podiatrists who are solely dealing with diabetic patients and rheumatoid arthritic patients, because what that form does, it gives you options to increase control, but you need to be really careful about increasing control with these type of pathologies. So they're kind of for people who have maybe seen the patients for years and years, and they know their ins and outs and what they can and can't tolerate, things like that. An EVA device then, it's a functional device, but it's just made from EVA. It's not as controlling as polypropylene. It's more, I suppose, better tolerated. But the only thing is with the EVA device, it has an EVA fill, because that's what makes an EVA device an EVA device. And with a fill, like I said earlier, it increases the bulk of the device. You'll see UCBL and Roberts Whitman. They're fairly similar in, I suppose, in practice of what you're trying to achieve for a patient. If a patient is an extreme overpronator and you're trying to add as much control as you possibly can, or yeah, if you're trying to, I suppose, okay, so I'll just kind of go through it. So a UCBL device has a 26 to 32 mil heel cup depth, which is huge, and that would be all around the foot. The heel cup would really fit nicely right around the foot to make sure that it's supporting the foot as much as possible. It's our most controlling device we have. It's usually used on children mainly, and these 3 types are mainly used on children, but they can be used on adults. But obviously, when you have a 26 to 32 mil heel cup, chances are you might have trouble fitting them into a certain type of footwear. So what I always say is, if you're thinking about a UCBL device, perhaps consider the Roberts-Whitman device instead. So the differences between the 2 of them is, instead of a 26 to 32 mil heel cup in a UCBL, a Roberts-Whitman has a 16 mil heel cup. So it's much better tolerated in fitting into shoes. While it loses out in the heel cup depth, it actually gains back up in control because we add a medial and a lateral flange to Roberts-Whitman devices. So it's much better tolerated. It's a better option than UCBL if a patient can't fit a UCBL device into their footwear that they want to wear. So it's just a really good alternative to it. Gait plates then, most commonly seen in children. It might be 1 foot over the other, or it might be bilateral. And it's basically a standard functional device with an extension either medially or laterally, depending on whether you're looking to promote in towing or to promote out towing. In a lot of cases, we might use this as almost like a therapy tool. And then you have the extension, and then after 6, 9, 12 months, the clinician would send the devices back to us to remove the extension, and the patient is then left with a standard functional device that they can wear for as long as they need. So that would be our gait plate devices, and that would be all of our device types. Next, then, I suppose the rest of the form. So this is really important to have your device types ticked. The rest of the form is completely a la carte. So you'll see in this photo, the top of the screen there, these are all of our shell materials. Down here, these are all of our top cover materials, bottom cover materials, and our forefoot extension materials, things like that. So usually when a customer would sign up with Firefly, we would send them one of these so that they have them to be able to look, feel, and touch what the materials are like and how they feel for their patient. Sometimes the patient is involved in the process themselves. The clinician might say, okay, I know I want a puff top cover, which we call which is our word for EVA. So this, from here kind of to here, they would all be puff. So then the clinician might give this to their patient to choose what colors they want to get them involved in the process. So these are our shells. These are the shells that we have. So you'll see here our polypropylene. So our vacuum form, this is our standard polypropylene that we spoke about in the device type section. So this would be probably a standard functional device. This then is our direct milled polypropylene. So you can see it's a unitized device, so it's all in one. There's no extra EVA on it. You can build your heel lifts into a direct milled device as well. Polypropylene is just a traditional shell material that's kind of been used for years and years, and everyone kind of knows polypropylene, and especially in the podiatry world, because that would kind of be the most common that they would see. Performance RX, then, it's a nylon reinforced thermoplastic, so it's a really lightweight, it's a really durable material, that it's approximately 3 mil, no matter whether you choose the rigidity of semi-rigid, semi-flexible, or rigid. The one thing to note is that with Performance RX, there are limitations with it, so we can't apply any facial grooves, we can't apply any gels, skives, or deep heel cups. But it is a really durable, robust material that's really lightweight and nice and thin. Next, we have our carbon fibers. So you'll see this is our TL2100 and this is our XT Sprint. So these are our 2 carbon fiber shell materials, apologies. TL2100 is an extremely rigid material. It's a true carbon fiber. So it would be mainly prescribed, it's really lightweight. It is a low profile, so it's good for dress shoes, but I would let you know that it is a rigid material that if your patient is potentially lighter, they might have intolerance issues with the TL2100. Whereas with the XT Sprint shell material, it's a different kind of carbon fiber. It's a carbon laminate. And this will be used for a lot of athletes. It would be used for a lot of runners, active patients, things like that, because it does have that bit of flex in it that the TL2100 doesn't. It would be lower profile than polypropylene, so it would take up less room in the shoe, and that's why it is our default shell material for our soccer sport devices. You'll see Delrin there as well. So Delrin is a high tensile crystalline material. It's been specifically designed for kind of obese patients or for heavy duty activities, or if a patient is kind of taking on a heavy load. Sometimes if your patient is in the gym and they're lifting really heavy, the Delrin will be the way to go for them. It's really low profile. It's a direct milled material as well, like our direct milled polypropylene, so we can build in heel lifts things to it, which makes it more durable because you're not changing out the EVA extrinsic roof postings. Okay, so that was our shell materials, and we also have 3D printed material, and it's made it's a PA11 sustainable material made from castor oil. So that would be probably our newest shell material that we have on board. It launched in 2020, and you can ask for a functional, a dress, or a sports, or a mold device, and just tick the 3D printed option. Rigidity then. So all of our products are semi-rigid, bar our standard mold and our low profile mold. If you want to change this, you can, that's no problem. But they are there for a recommendation for a reason, really. Most patients, semi-rigid will be perfect for them. There are patients who may be lighter that they will require semi-flexible. If it's a thing that there are any intolerance issues or anything, we can just get the devices remade into a lower thickness material, so that they can feel the benefits of something being semi-flexible if needed. A fill material then, that's where underneath the actual shell will be filled up, as I spoke about earlier. Pour-on would be the most common for shock absorption. EVA would be for your diabetic tridensities and your EVA device. Cork would not be predominantly prescribed because it would be really stiff. So when you're adding fill materials underneath the shell, you're actually stiffening up the device itself. So you wouldn't want to stiffen it up with something like cork, which would make it really, really, really rigid. Forefoot extension then, that would be basically where you want additional forefoot cushioning or stiffness. So pour-on would be our gold standard for cushioning. Niplex would be our gold standard for shock absorption. So Niplex can be used as a bottom cover or as a forefoot extension. Cushion cork and puff, which is EVA, they would mainly be used to maybe increase the stiffness of the forefoot if required. And they would be from the distal edge of the shell to either sulcus or to toes, whichever you choose here. Top cover selections then, so these are our top cover selections. We have a wide range of colors and different types of materials, but we couldn't fit them all in on our order form. On the app, on our Fusion app, you can see all of our top cover materials that we have, but we can't fit them all here on our standard order form. So these would just kind of be our most popular. So vinyl is really durable, really wipeable. Leather, I suppose it'll be your cheaper alternative to leather. Microsuede is used as default for our ladies' dress devices. WSL carbon would be a stiffer kind of vinyl. It's usually used more frequently as a bottom cover for our carbon fiber shells, because over time, when the patient's wearing carbon fiber shells, they can get sharp at the distal edge and tear the bottom cover. And that has absolutely no effect on the functionality of the device, but aesthetically it mightn't look as good. Neoprene then would be that wetsuit material. It'll be used in our standard sports devices. It's really durable and cushioning. Plastizote then, I think everyone has kind of seen Plastizote. It's kind of that fleshy colored material that will be used for a diabetic tri-density devices. Wherever we would see Plastizote, we actually changed that to a different material that we have called P-Cell, which is less porous than Plastizote and much more durable, because Plastizote can break down very quickly. Puff then is EVA. Bambulon is a material that's been specifically designed for patients with hyperhidrosis. There are antibacterial properties within the actual material itself. But one thing to note is that when you prescribe Bambulon, that the material will require more frequent refurbishments than other top cover materials. Apologies. Combine material that's basically that you want one of these top covers to be combined with a cushioning mid layer, and that's usually of Poron, because Poron is our gold standard for cushioning, and that's either 1.5 mil or 3 mil. Length then is really important. So this basically decides what length device that you're going to get. If you leave this blank, we will go for the length of our default in our catalog. So for instance, if you want a standard functional device and you want it to toes, but you don't tick to toes, it's automatically going to come to METs because that's the default in our lab catalog. So it's just something to keep note of. Bottom cover selection. So any device that's sulcus length or to toes, we would add a bottom cover as default to protect perhaps a mid layer, to protect perhaps an addition or extension. So we have Agroflex there. That would mainly be used if you choose a really thin, flimsy top cover and nothing in between to kind of reinforce it. Agroflex would be a really stiff material. It's more for stiffening those kind of flimsy materials and for it to keep its shape. Vinyl then would be used in most of our products. Puff, which is EVA, isn't commonly used as a bottom cover because it just adds that bit more bulk. Niplex would be our shock absorbing bottom cover that would be found in our mold devices, in our impact sports devices, and in our ORA soft mold devices. Microsuede would be if you wanted something a bit grippy and light and thin. And WSI carbon, like I said, is for the carbon fiber shells. Okay, so now we're into the posting section. So you'll see here, these are the options here. So lab evaluation, basically what this means is you are not 100% sure on the prescription that you need some help. I would say if you're going to take lab evaluation, to write in the special instructions on the bottom left of our form, please call me, just in case this is missed, because that is super important. Like I said, we want to stop the train before it leaves the station. Then we have things like measurements from vertical, calc vertical, and neutral as they sit. If all of this was blank, what we do as default is we correct everything to calcaneal vertical. We then add an extrinsic rear foot post, and we balance the forefoot to the rear foot. If you were to leave completely this whole section blank, that's what we do across the board. That is our lab standard. If you tick neutral as they sit, and I'll show you, or tick calc vertical and neutral as they sit. So it would be posting to vertical. So you'll see there on the back of the left device and on the back of the right device, they have been marked. So that would have been marked with a kind of a perpendicular line in the lab. What this tells us here is that it's not a great photo, but what this tells us here is there's probably not much posting that needs to be applied to this product to get it to calc vertical for when we're scanning it. But for this device here, we would need to add an EVA wedge there to bring this to calc vertical before we scan it. If you had chosen, apologies, neutral, we would scan exactly as it sits. We wouldn't add an EVA wedge here to get this line perpendicular. We wouldn't do that at all. We would scan exactly as is. And what that means is we wouldn't be adding posting to the device before it's scanned. Whereas for this, we would be adding posting. We would be adding a level of degree, probably 3-4 degrees, to get this to calc vertical in particular. So that is our calcaneal vertical and neutral as they sit. Rule of thumb really would be, if your patient has a cavoid foot type, to choose neutral as they sit. And why I say that is, if your patient is supinating and we're trying to correct it to calc vertical, what we're actually doing is we're lowering the MLA. So it's not a true representation of that high arched foot at all. So if we keep it as neutral as they sit, when it's scanned, it's a true representation of the patient's foot. Then we can add postings from that, valgus postings from that. But that's just kind of rule of thumb. Or if it's a thing that you have, maybe a patient who is hypersensitive, and you're afraid that if we correct calc vertical, we could almost be adding too much posting to get it to vertical. You want it neutral as they sit, and it's all about, I suppose, where your reference point is. So our reference point is usually correct calc vertical. If you had 3 degrees posting on left and right, or on one over the other, we'd correct calc vertical. We might end up adding 2, 3, 4, 5 degrees to get it to vertical, and then from that we are adding the 3 degrees. All of our posting is always applied intrinsically in the shell. The only difference between extrinsic and intrinsic is that intrinsic is a rounded heel cup. Extrinsic comes with a stabilizing EVA post, and I'll show you here. So this is the difference between extrinsic and intrinsic. So this is your extrinsic. So the posting is already applied in the shell. Like this, posting is applied in the shell. The only difference is extrinsic has an EVA stabilizing post, whereas your intrinsic will come like that. It'll come rounded. And that's just kind of something to note there with extrinsic and intrinsic. All of our posting is always applied in the shell. So if you take intrinsic, you're going to get a rounded heel cup. And that's just something to note. Forefoot posting, then, if you leave this blank, we always correct to the rear foot, or balance to the rear foot. The only times really where you'd see extrinsic forefoot posting, maybe to sulcus or to toes, is if a patient has a true forefoot varus and you're trying to, I suppose you're trying to make the ground meet the patient's forefoot that little bit quicker. Skives, then, they are curvy skives. Predominantly they're medial skives, but if we have valgus posting here, it will be a lateral skive, or you can always ask for a lateral skive instead. And I'll just show you the difference here between rear foot postings and skives. It's just a little illustration that might make things a little bit easier for yourselves. So you'll see here, this is varus posting. So varus posting is applied medially, usually for a pes planus foot type. So that would be kind of how it would be applied. Your valgus posting then would be applied laterally, and that would usually be for a pes cavus foot type. And then this then is your skive. So this would be a medial skive, and that just shows how much more aggressive a skive is compared to rear foot posting. So that's something to keep in mind. I'll go back here. So yes, they will be your skives. One thing to note as well, a skive will have a knock-on effect with the heel cup depth. So if you require a 2 mil skive, you will need to have a minimum of a 14 mil heel cup. A 3 mil skive would need a minimum of a 16 mil heel cup. A 4 mil skive will require a minimum of an 18 mil, and you'll see in the next section they're kind of increments. So 14, 16, 18, 20. I don't know why that keeps going down. 14, 16, 18, 20, 22. So 2 mil skive will require 14 mil heel cup, 3 mil skive will require a 16 mil heel cup, 4 mil skive will require an 18 mil heel cup, 5 mil skive will require a 20 mil heel cup, and a 6 mil skive would require a 22 mil heel cup. And that's why they're in those increments, just to make things easier for yourself when you are deciding on skives and knowing that it has a knock-on effect to the heel cup depth. Inverted, so that would be inversion. So what we would be doing is we're actually inverting or everting the entire device. So it's different to rear foot and forefoot posting, where we would bisect the rear foot and actually put the angles of degrees of posting in there, and then kind of match it back with the product itself, or with the rest of the device, the kind of MLA in the forefoot area. Whereas this would be inverting or everting the entire device, whereby you're lifting the entire medial aspect. So the first under your first MTPJ of the shell, so the distal edge of the shell, that might be raised. And what it could cause is slipping. To be honest, inversion and motion are not regularly prescribed. I'd say there's probably less than a handful of podiatrists who prescribe it. It all depends on your school of podiatry and what years you were taught in. Motion then is where, and I'll just show you here on this image, motion then is where there's a grind off laterally and medially of an EVA rear foot by a level of degrees. And what that would do is it would promote rocking in the shoe. But I suppose predominantly you don't want the device to be rocking in the shoe, because the shoe acts as a buttress for the device. So they're not commonly prescribed, or they're not commonly requested, like I said, but it's not something that we would usually promote. But it just depends on the school of podiatry that you've gone to. Then we are on to, I think I'm after skipping something. Okay, then we're on to cast dressings. So what cast dressing is, it's basically the distance between the product and the patient's foot. So you'll see in this illustration here, minimum is our lab standard. If you don't take cast dressing at all, minimum is our lab standard. So what that means is it kind of comes from where traditionally all of the orthotics were poured manually and the plaster was manipulated manually. And here is where they would have applied more plaster onto the positive mold to create more of a distance from the patient's foot to the orthotic. And in that case, the reason why you'd want to maybe create a bit more distance is if the patient had tissue spread. So you need to allow for it. So allow for that heel expansion. Whereas if you don't add as much plaster at all, then it will be a tighter fit to the patient's foot. So you'll see there type 1 and skin. So there's approximately 2 mil of the difference between all of these increments. Minimum is our default, it's our reference point, it's our standard. If you want a 2 mil tighter cast dressing, you'd go for type 1. If you want a 4 mil tighter cast dressing, you'd go for skin. If you want a 2 mil looser cast dressing for minimum, it's moderate. If you want a 4 mil looser, it's maximum. The only thing to keep in mind is that when you're asking for skin cast dressing, which is a total contact insole, that you need to take into account what top covers you've asked for, whether you have a pour on arch pad, because all that is going to bring the device up even further into the patient's foot, and you could have intolerance issues. So I suppose rule of thumb really would be minimum as standard, unless you want to provide more control or allow for heel expansion for maybe the tissue spread. Modifications then, I suppose these are all kind of self-explanatory. So in our catalog, we have the explanations of all these, when you'd use them, and kind of, I suppose, when you wouldn't use them. So there, your first med cutouts will be to allow your plantar flex, to allow your first plantar flex. First ray cutout is just increasing that kind of surface area. A rigid first extension will be if a patient had a functional hallux rigidus. So it's rigid, so you want to splint it. That would be of shell. So this is under shell modifications. So these are all to do with the shell. They're not to do with soft materials. Medial flange for increased control, lateral flange if a patient has maybe lateral ankle instability, a narrow shell grind and a wide shell grind. That's basically you're getting your either your functional, your dress, or your standard, and you're narrowing it by 2 mil each side, or you're widening it by 2 mil each side to maybe increase surface area if you need that for the patient for increased control, or if you're worried about shoe fit, you might go for a narrow shell grind. A facial accommodation then is when the plantar fascia band has actually protruded from the patient's foot. What we would do there is we would groove out this area in the orthotic, and we'd fill it up with Poron so that that band is not hitting against shell, because that could be really, really painful. Heel spur accommodation, if a patient has a heel spur, what we would do is we would gel it out, so it's almost like I get my finger and I push that area out, I fill it with Poron so it's nice and soft. And similarly for a heel hole, it's just a little bit of more area in the heel surface, and you can fill that up then with Poron or with gel, which is silicone. And then sweet spots then, so sweet spots are where there might be a bony prominence out of your patient's foot, predominantly in your navicular, your medial cuneiform, your base of first met, base of fifth met, your cuboid area, or your styloid process. And that would be where we would get the sweet spot, like similar to the heel spur accommodation. We would push that area out, we'd fill it with Poron, so that bony prominence isn't coming down on shell. And with the sweet spots, it's really important to mark where you want the sweet spot to be applied. On the foam box or on the cast, or if you're scanning, like Conor will go through now, on the patient's foot maybe, because we can actually see then on our side where you've marked from the scan. Then additions, these are all kind of pretty self-explanatory as well. Heel lifts, I suppose, if your patient has a leg length discrepancy, or if your patient has maybe tight calves, you'd always kind of apply even around a 3 mil heel lift, just kind of elongate the muscles. The heel pad then would be just extra cushioning in the heel. All of these illustrations are really, really good to follow, because they show you exactly where these additions are applied. So your met pad, met bar, met raise, they're all made out of Poron as default, but it's just the actual width of them. So met pad would be kind of more localized, it's kind of your second and third. Met bar would be kind of 2 to 4, and then met raise then would be 1 to 5. And then lesion accommodations, if you want to offload for a callus or a corn or something, this is where you choose lesion accommodation. Then Morton's extension is similar to our rigid first extension that I spoke about for functional hallux rigidus. But the Morton's extension is actually much better tolerated. It's made from cork. It can be to sulcus or can be extended to toes. If you wanted it to toes, you need to specify, because sometimes the patient might find it uncomfortable underneath the first layer that it's actual shell thickness, and so the cork sometimes is a good option. And then it's all about then promoting movement or limiting movement. So I'm going to come here now, and if anyone has any questions on those before we let Conor go through the digital scanning, because I know I've kind of went over time, but does anyone have any questions there for me?
Can I just say as well, remind people to click the link there to get on the mailing list so we can forward you this presentation afterwards. And
yeah,
we'll also send you some bits and pieces related to education and the prescription of custom-made for orthoses over via email. And you can also unsubscribe from the mailing list at any stage. But it will just help us keep in touch with you as well. So I guess the takeaway from Sorcha's presentation there is that the prescription process of custom-made for orthotics is quite detailed, and you know, it kind of emphasizes the value of the technical support that Firefly offer, because there's so much going on there. You know, the podiatrist, I think, Sarah, it's fair to say the podiatrist's goal is the primary goal is to identify the pathology and have a reasonable idea of, you know, the orthotic design that's going to best accommodate that pathology or treat the condition. And Firefly's technical support then is there to answer the kind of get into the nitty gritty and advise on the most appropriate shell, rigidity, shell type, accommodations, and so on.
Yeah, absolutely. That's it. Exactly, Conor. I mean, when we get calls or emails from clinicians who have a patient, they've seen a patient last night, they've seen a patient this morning, and they want to discuss the prescription. They have in their head, okay, well, this is the problem, but they might know exactly how to apply our additions, extensions, and even choose our device types to be able to kind of, I suppose, help with the problem. And I suppose it's our way, it's our, I suppose, possible or responsibility then to try and translate what the clinician wants to do into an orthotic. And that's what we do. And there's a lot of, I suppose, knowing what the patient needs, what the diagnosis is, carrying out your biomechanical assessment, having previous issues noted. All of this is really important because that gives us an idea as to what we need to do to help go forward in the design of the prescription. And we can then advise, okay, well, we could maybe go down this route, or we could maybe go down this route. And another thing to note is just that there are so many ways in orthotic therapy to do the exact same thing. You know, there's a lot of ways to skin a cat, but you can do this way, you can do this way, and it'll actually have the exact same result. But that's just something to note with that. But it's definitely and like you said at the start of this, at the top of this, that it's our more, I suppose, established podiatrists who really lean on us because they know that we're there to, sometimes even all they want is affirmation that what they're doing is right, and that we have no other ideas in our heads as to what they should do. But yeah, sometimes a bit of an ear, and maybe someone to lean on. You might be in your clinic by yourself, or you mightn't have all that support around you. Like, we are that support.
So the question there, Sorcha,
Yeah.
from somebody to say, I'm just coming up here. Can you see it? Do we
have to follow the same procedure when we are prescribing for children? Yeah, so you still need to carry out your biomechanical assessment. I suppose really with children, it kind of depends on whether you want to go down the custom route. I know that there are clinicians who just maybe go for an off the shelf. But for us, we would say if a patient requires a custom-made foot orthotic with a deep heel cup, something like a UCBL, something like a Roberts Whitman, something like a gate plate, you're not going to have that from an off-the-shelf device. And that's where our outgrowth program comes into play, where we know it's costly, we know the patients are going to outgrow the devices, but we have that program in place. But as long as you have the date of birth of the patient on the form, we can register them, and then we can keep an eye on when they need recasts and things like that. But if without that information, we don't know how old they are.
Can I just ask you about the prescription process? So when a podiatrist places an order for a set of custom-made foot orthotics, what happens after that? Is it a case of the patient showing up to the clinician, putting them in the shoes, and away they go, or is there potentially more steps after that?
Yeah, so I suppose one thing to note is another thing to note. I keep saying another thing to note. Another thing to note would be when you're fitting devices. In a lot of cases, the devices may not fit into the shoe 100% from get-go. You need to make sure that you have a sharp scissors in your clinic. We would finish all of our devices to a standardized template. And as you know, different brands, different shoe types have different toe boxes. So one thing to really have is a really nice sharp scissors to be able to, perhaps if there is a removable insole, to pull out the actual insole from the patient's shoe, use that as a template guide and cut around it. In fitting, you might find that the device is maybe slightly too wide. You might just decide that the patient maybe tries them on, they really don't like a Met pad, for instance. So we have an 8-week free of charge adjustment kind of period. So once the devices have left Firefly, there's 8 weeks for you to send the devices back for us to make any changes. So things like that. So you're not kind of, I suppose, we're not punishing the clinician, and we're not punishing the patient by asking for, I suppose, a fee for changing any of these things, because it is a lot of trial and error when it comes to custom-made foot orthotics. Our devices are hand finished. I suppose with that comes the main custom made, I suppose, the main custom made aspect of it. And you know, maybe a patient mightn't get on with X, Y, or Z, but by you guys knowing that you can get that changed or you can add it in, maybe when the patient is wearing the devices, you might feel, or they might feel like, oh, I mightn't be getting as much support as I may have thought, or something. You can send them back to us and we can have a look at it and we can discuss with you then what are the next steps. We could add maybe a pour an arch pad maybe. But I suppose this is where the kind of the communication, especially at the start with new customers and things like that, comes into play, where we would discuss the prescriptions in detail, just until they're comfortable with what they're prescribing. But like that, you never really kind of let anyone go. You never really let anyone go. You're still there for their support as needed. And I hope that answered your question, Conor.
Yeah. Okay, look, it's 10 to 11. So if anybody has any further questions, let us know. Otherwise, if a question comes to you, can you tell us the difference, Sorcha, between EVA and pour-on?
Yeah, so pour-on is more cushioning, EVA is stiffening. Even your low density EVAs would be stiffer than your pour-on. Pour-on is kind of there for shock absorption. EVA is more of kind of a functional type. I assume you're talking about the fill materials. It would be more as a functional type of material to be used. So yeah, so anything that you require shock absorption for, or if you're trying to make the device more accommodative, that's where you would go for your pour-on over the EVA. The EVA, yeah, sorry.
What I'll do after this is those who signed up to fill in the form, the contact form, I will send people one of our more popular blogs on the fireflyorthoses.com website, and it covers materials, kind of gives a breakdown of the different materials and when is the most appropriate kind of context in which to use them, and how they're just the profiles of each of the different materials. So it's helpful for people. And if you fill in the form and you think a question that comes to mind later on, we will get back to you, or you can email Sorcha or myself. You can email Sorcha, sorcha@firefly.ie, or myself, Conor, CONOR, @firefly.ie, or you can email info@firefly.ie. So, okay, Sorcha, Sorcha's just put her email address into the chat there. Just remind people again that the link to the form is at the top of the chat. Just click it and put in your details so we have you on record. And okay, so we've 9 minutes to go. Sorcha, thank you very much.
Thanks, Conor.
What I'm going to do now for the next few minutes, very quickly, is just talk to you a little bit about patient anatomy capture and how that happens in relation to kind of more contemporary technologies such as an iPad and what's called a structure sensor scanner. So traditionally, patient anatomy would have been captured by the podiatrist using plaster of Paris along with a basin of water, and they would take a negative, the covered that with plaster. They'd take a negative impression of the patient's foot. That would be put into a box. Well, first of all, you need to wait for it to dry and to set. To remove it then from the patient's foot, put it into a box, walk around to the post office or drive to the post office, put it into the Royal Mail postal system, cross your fingers, hope that it doesn't get bashed around too much in transit between the clinic and our lab, and then it arrives to us. When we open her up, and we will begin the manufacturing process from that negative mold. We would take a positive mold, and if they're vacuum formed devices, the polypropylene or whatever the shell material would be vacuum formed over that positive cast from the or positive mold taken from the plaster of Paris cast. So just in that timeline alone from the podiatrist capturing the cast of the patient's feet until it gets to Firefly, there's a lot of things that go on in there, and there's a lot of things that can go wrong. For example, if the podiatrist does not allow the cast to dry completely and it's put into a cardboard box to be posted to the lab, it can fall apart because it's still moist, or you lose the shape of the anatomy, and then the device that's manufactured is not a match to the patient's anatomy. So to counter all that, and I've covered my desk in lots of plaster, to counter all that, we more and more see our customers, not just our customers, but podiatrists who are placing orders with orthotic labs using handheld scanning devices that clip onto iPads like such. Like this is a little bracket that just sits onto the top of the iPad, and there's a little wire that goes into the side. And what I'm going to do now is just share my iPad screen so you can see what I'm going to do here. This is going to be very quick. Oops. Here we go. Oh, it's not allowing me to connect for some reason. Here we go. So can you see my iPad screen? So this is the Fusion app. So we've developed an app that will allow practitioners to capture patient anatomy by scanning the feet on an iPad. And it's quite a simple and quick process. So you can capture the scans of your patient's feet in 20 to 30 seconds, where a plaster of Paris cast might take you 20 minutes. And you can hit send on the app and submit the scans and your prescription to Firefly within a couple of minutes. There's no need to bring things to the post office. There's no risk of cast getting bashed around or broken while in transit. It's a much faster turnaround time. And what we've done is we've built the Fusion app, which is available from the App Store. It's built specifically for iPad in conjunction with the Sorcha sensor scanner, and allows you to scan your patient's feet and create a prescription all in one place. So I'm going to do this very quickly just to demonstrate how it works. So this is the dashboard. And you can see in the top left-hand corner, we've got the scanner battery status. That's the battery status of the Sorcha sensor that's attached to the scanner. In the middle, we've got our iPad battery status. There's only 80%. Down here, we've got all the patients that I've seen and I've captured scans for, and I can see when they were placed and what status the order has. For example, this test here has been shipped. The test has been submitted. It means it's been manufactured. The purple status is being shipped, and it's self-explanatory. In review means that they're being reviewed by our lab, and incomplete means that the order hasn't been completed. It's missing a scan, or it's missing an element of the order form. So I have a model foot on my desk, and I'm going to scan this quickly just to demonstrate how this all works. So you can see on the left-hand side, you've got a navigation menu. The first thing we're going to do is tap the scanner button. It's here. It'll ask us to enter in the patient's name. I'm going to say Conor Lynch. Hit done. Actually, just in case I'm going to write test at the end of this. And then we hit set. And now you can see my desk with spots of plaster around the place. Now what we're going to do is we're going to scan the patient's foot. So you can see there's a bounding box within which we want to place the patient's foot. And I can manipulate the size of the bounding box by pinching on the screen. So if I pinch, do this more slowly. If I pinch, I can make it smaller or I can make it wider. And the idea is to get the target object, in this instance, the patient's foot, into the bounding box. Now you can see there's a color rendering. You can see the blue color, that's telling me that I'm too close. If I move away slightly, I get that green color. The whole plantar aspect of the foot has that green rendering, which is good. If I move further away again, it turns red and it tells me I'm too far away. So I want green. Green is good. At the bottom left-hand side of the screen, I can see that the left foot element, or the left foot is in grey. This tells me the container that we're operating in. I can just tap the right foot if I'm scanning the right foot, and this is a right foot. So I'll tap the right foot. And then the bottom right hand side of the screen, it says scan. And once I hit the scan button, it'll very quickly start to pick up the data. And then you just rotate around the patient's foot to make sure that you get all the medial and lateral aspects of the anatomy. And I think I'm happy with that. I'm going to hit end scan. It will automatically give me a preview of what I've just scanned, and I can assess that to make sure that I've captured everything that I want. And I'm happy with that. I've captured all the anatomy where I anticipate there's going to be an orthotic. So I'm going to end preview, and I'm going to capture, obviously, the same foot. But you can see now it's automatically jumped from the right foot container, and the text is turned green here to tell me that I've captured anatomy, and it's now jumping into the opposite foot. So I'm going to scan the right foot again into the left foot container, just for demonstration purposes. So you can see how quickly I can pick up the data. It's pretty robust. It's telling me to slow down, but this is just a demonstration. And scan, so now the left foot should turn green after I review my scan. I'm happy with that. Left foot is turned green. The next thing we're going to do is we're going to tap the order form button on the left-hand side navigation menu. We can see that the patient name has been brought across from when we've done the scan. And this is the order form and all the elements that Sorcha had spoken about in her presentation. I'm not going to go through it all again, but I'm just going to race through quite quickly just to show you the process. So you can see if I want to hit the next button here, it won't let me progress until I fill in some required piece of information, like the patient's weight. This is hugely important. Say 88 kg. We have to have the patient's shoe size. We say 9.5 UK. We can select the gender of the patient. We can put in their date of birth. We can put in their footwear. The more information, as Sorcha says, the better. It gives us more context, and it allows us to manufacture the most appropriate device possible for the patient. I'm going to tap next in the bottom right. I'm going to select, this is a bilateral order. I'm going to select the functional device type for everyday pair of shoes. I'm just going to order one set. Move on to the next page. I'm going to choose my shell material. This is going to be a default polypropylene functional device, semi-rigid. No film material. Progress on. And you can see here, there's different tabs under this, and there's different pages under this optional specs tab. These are all the details that Sorcha spoke about. So you can get as detailed as you like with your prescription. However, if you just select functional polypropylene device, the device will be manufactured as per the default spec on our website and in our product catalogs. So I'm going to jump towards the end here. It's our posting section. And we're nearly ready to submit the order here. I can put in any additional information, such as if I, we usually turn around our devices within a 10 working day period. And if I'm a podiatrist and I know that my patient needs them maybe a little bit quicker than that, I can put that information into the additional information section here. We'll progress on. It just gives me a textual summary of the order that I've just created. I'll move on to the last page. This is the shipping information, so this is determining where this order is going to go. By default, it'll go to the podiatrist's clinic, the clinic address, or you can ship it to patient, or you can ship it anywhere else in the world. And the last thing to do is hit the submit button. So it tells me the order is sent. It's in a pending status, and it should progress to in review. Here it is here. Order 56765 for a functional device, ordered today. In review means that it's been received by the lab and it's been reviewed by our operations team to make sure that all the information is correct and they have everything they need in order for it to go to the next stage, which is submitted. And while it's being submitted, while it holds the submitted status, it's in manufacture. So that's how quick and easy it is to submit an order using the Firefly Fusion app. And one thing to say about the app is that currently we require the third-party structure-centered scanner. And quite soon, I would anticipate that we're going to move away from the requirement of the scanner, because a lot of iPads come with what's called LiDAR technology, and that's inbuilt 3D scanning technology. So there won't be a requirement for the podiatrist to have to purchase the additional structural sensor, which costs about £300 or £400. That is a very quick demonstration of the scanning technology. So I see someone's just asked there, what is the turnaround time for both your custom-made orthotics, and bespoke orthotics? Well, I guess we would say custom-made and bespoke orthotics are the same thing. And their turnaround time is between 10 and 12 working days at the moment. Thereabouts. Is that correct, Sorcha?
Yeah, and you might be talking about semi-bespoke. So our off-the-shelf, it's between 4 and 6 working days from receipt to dispatch. It depends on how complex the prescription will be.
Yeah. Just in relation to the digital scanning, like a lot of it, and you know, if you're sending in plaster of Paris or a foam box, it's going to take 2 days usually to reach us, and it's going to be another 2 days to send it back out. So that's 4 days. Using scanning technology obviously eradicates the inbound shipping time, so it's a faster turnaround time. Any other questions in relation to the scanning process? Or any other questions at all before we finish up? I know it's now nearly 11:05. Thank you very much for joining us this morning. Really nice to be able to present to you, and hopefully we could do these in person in future. But they just have become, on the back of COVID, they've become quite a handy way of connecting with the student body across Ireland and the UK.
Brilliant. Thank you, Conor.
Thanks, Jill. Yeah, as I said, it's been recorded. Again, do you know what I'm going to do? Just before we finish up, I know people want to get away.
I was busy typing one question to you, but I've given up typing. I'll ask you it.
Sure.
I really like the idea of the 3D scanning. I've yet to do it, and the reason for, well, apart from the fact I don't have an iPad, I'm Android, and that's always bugging me a bit. And I don't like to feed the Apple giant too much, unlike my rest of my family who can't have anything but Apple. When most of my patients, they're near enough all pronating. Generally, I say 90% of them pronate, and therefore they've near enough always got a 4-foot soft tissue inversion, a supinatus for want of a better word there, if not the first ray sort of pushed up into dorsiflexion. So when I'm casting them, not only have I sort of got them into neutral, trying to keep that ankle at 90 because of the equinus that's kicking in a little bit, getting the first ray down into its position and correcting the forefoot a little bit, because I always feel if I can do it on the cast, it's better than doing it on plaster additions that the lab do, because it's going to be a more natural position. By the time I've done that, I haven't got anything left to hold the scanner with.
Yeah, so I would say I think that's a very valid point. Yep. And there's no escaping that. So I think there's a couple of considerations here. There's the level of confidence that the scan that you capture with the 3D and the anatomy that you capture with the 3D scan will be appropriate for the pathology and the device type. However, we would say that for more complex pathologies, when you need to position the foot in a particular way, the scanning using 3D scanning may not be appropriate, unless you can get somebody to hold the foot in place for you. And if there's a couple of fingers in the scan, across the med heads, that's probably okay. To some degree, we can remove that in the design process. What happens from time to time is that a podiatrist will scan the patient's foot, and they might also take a foam box, or they might also plaster of Paris cast the patient as a backup. They'll submit the scans to us and they'll say, is the scan appropriate? Alternatively, I have a backup plan. And I know that might defeat the purpose of scanning if you're going to have to capture plaster of Paris as well. But then ultimately, that again, Jill?
Not to mention the cost to the patient.
Cost to the patient, yeah. But what happens then over time is that you become more confident in what is appropriate, what scans or what pathologies or foot types are appropriate for for scanning.
Like there will always be certain pathologies that aren't suitable for scanning. So it's never going to be a time where we're ever going to not accept plaster Paris or fun boxes or anything like that. But I think what we've seen for some of these patients who can kind of keep that themselves, not all patients can kind of keep that that kind of position that you've asked them to keep still, and in a lot of these cases where they can't, sometimes we see that maybe the secretary comes in and scans while the podiatrist would hold it, or vice versa, or the podiatrist would ask the secretary to come in. And I mean, that's something that we do see if it's a thing that the patient can hold it. But to be honest, in a lot of cases the patient can, once you have them in that position, because it's so quick that it's only there for 20-30 seconds on each foot, and like that there is a level of degree that we can make corrections in, but I know that you want to kind of have it in that position before it even gets to us. But yeah, it's definitely something to maybe think about if there was a secretary or something there to help. Not everyone has the luxury of having someone there all the time though, which we understand. But that's kind of the way that we've kind of seen people make their way around it.
Yeah, I think it'd be nice if you could like pin it to your head or whatever, and so it voice controlled, or with a wink and
that could be the next thing, Jill.
Do that, it's my credits.
Yeah. You're onto something.
Or whatever, yeah. All right, lovely. Thank you ever so much. I don't know if the students have put any other thing in the chat. I didn't see anything, so
Yeah.
No.
Okay, well, look, just to say thank you, Jill, for facilitating us. Thank you, Sorcha, for your presentation. And thanks to James as well. And we are contactable at any stage via email if you have any questions, or if anything comes to mind, we'll be delighted to answer them. And we hope to see you in person. We're going to the Royal College of Podiatry conference in June. It's June, right?
Yeah, July.
July, yes.
Yeah.
In July. And yeah, if you're there, say hello to us. Otherwise, have a great day.
Yeah.
Lovely. Thanks ever so much, Conor.
Thanks, everyone.
Okay,
Thanks,
guys. Take care. Bye-bye.
Thank
Take
you.
care. Bye now. Bye-bye.
Thank you.